Okay, everyone, welcome back to Chapter 17. This is going to be our last part. The focus of Part 3 is going to be on platelets, very similar to when we discussed the erythrocytes and the leukocytes. We're going to focus on their function and, of course, their developmental pathway. And then towards the end of the chapter, we're going to talk about something very interesting, which is blood typing and how it's determined from a genetic standpoint and how it will determine who and who not you're able to transfuse or share blood with. Alrighty, so let's begin with our platelets. This is our last formed element to discuss. Now remember, platelets are not actually considered cells. They are fragment pieces that come of this very large cell called a megakaryocyte. And in a little bit, I'll show you a visual aid that will actually show you how large this megakaryocyte cell is going to be. But for now, I just want to introduce the platelets. Their main function is going to be involvement in the clotting process. This is very important because, as you can imagine, if you ever have damage through your blood vessels and you start bleeding, your body wants to make sure that it minimizes the amount of blood that is lost. So the platelets will play that very important role of kind of clotting up or closing up the blood vessels so that you can hold on to as many of your formed elements and your plasma as possible. There are different chemicals involved that will make a clotting process completely successful. So as you can see in the middle of your PowerPoint, you have a few of them listed. Serotonin, calcium, there are different enzymes. We're also going to talk about platelet-derived growth factor. And to be very honest with you, probably the most important chemical here is going to be calcium. Calcium is going to be involved in several aspects of the clotting process. We'll also discuss how on a average typical day when your body is completely healthy and there's no need for clots to occur, how exactly it goes about keeping those platelets inactive and mobile so you don't have any unnecessary clotting that can occur. And part of how it does is that it turns out that within the plasma you have lots of nitric oxide and prostacyclin floating around, and they're able to interact with the platelets, allowing the platelets to just keep flowing and not clot together, thereby hindering the blood flow. Prostacyclin is probably the one that's best studied. Prostacyclin comes from the endothelium cells that line the blood vessel walls and allow the lumen of the blood vessel to almost have like a slippery component so that the platelets, even if they want to adhere, are not able to do so because they'll slide right over from one side to the next. The process of producing platelets is called thrombopoietin, and very similar to when we talked about our erythrocytes and our leukocytes, it will start within the red bone marrow with our hemopoietic stem cell. Now, this will come, and we'll see as we discussed with our leukocytes, our hemopoietic stem cell can be divided into our myeloid line and our lymphoid line. The myeloid line will be the one that will take care of platelet formation. That is the same line that we discussed when we looked at the formation of all our granulocytes, so all our fills, and also the monocyte. Either way, when it looks at the platelets, it turns out that from a developmental aspect, the first developmental cell that will come from the committed cell will be called a megakaryoblast. And the megakaryoblast cell is going to be important because it turns out that this cell will continuously do cell replication or mitosis, but it will not do cytokinesis. Cytokinesis is splitting of the cytoplasm. So that means that as the cell is replicating, it is getting larger and larger without actually dividing and increasing its number of cells. So what we see happening is that over time, the more mitotic cycles the megakaryoblast does, the larger it becomes. And at a certain point, it gets so large that the name will then alter from megakaryoblast to megakaryocyte. And the megakaryocyte is the cell that we need because it turns out that it's going to go ahead and inject itself into the blood flow through the blood vessels, and it's going to start fragmenting its plasma membrane and cytoplasmic content. And as it's doing so, those little fragments that are being broken off, those are going to be the platelets. And usually platelets have a relatively short lifespan, about 10 days. Now, go ahead and take a look at the image that is on the right-hand side, primarily the bottom image, and you're able to see a megakaryocyte being illustrated for you. Notice how much larger it is compared to your red blood cells and your white blood cells. This is a massive cell, and in fact, you're actually able to see it with the naked eye. It kind of looks like a little dot made by a pencil, so you can't really see a lot of detail in it, but you're still able to visualize it with the naked eye, which is pretty cool for a cell overall. Also notice in the illustration how it's able to go ahead and interact with your blood vessel. And as it gains entry into the lumen of the blood vessel, notice how the fragments of its cytoplasmic contents are broken apart. And these will then give rise to our platelets, as I was discussing before. The top picture shows them a little bit more colorful thanks to an electron microscope. And you can once again see how it has these little pseudopods, these little cytoplasmic extensions that will be breaking off to give rise to our little platelets. Now here is our developmental pathway from an illustration that looks very similar because we've talked about it in the erythrocytes as well as in the leukocytes. So it makes sense to have an illustration very similar for our platelets. As you can see, the story will start very similar with our hemopoietic stem cell. So we're still in the red bone marrow. It is the same stem cells that will give rise to all formed elements. And once the signal has been received, we see that a committed cell will form, and we start seeing our developmental cell of our megakaryoblast. And the megakaryoblast will go ahead and start doing mitosis and getting larger and larger and larger because it's not doing its cytoplasmic division of cytokinesis. And what they tend to do is, depending on the size, they'll stage it. So on your screen, you can see that it says stage 1, stage 2, stage 3, and at a certain point, it's large enough that we go ahead and upgrade it to a megakaryocyte. The megakaryocyte is then the one that will release its fragments into the bloodstream, thereby producing our platelets. So hemopoietic stem cell makes our megakaryoblast, makes our megakaryocyte, and gives rise to our platelets. So how exactly do platelets perform their function of blood clotting? Well, it turns out that they tend to do it in 3 particular steps. The whole process is called hemostasis, which is the scientific way of saying that there are a series of reactions that need to occur whenever you have bleeding within the blood vessels. Now, in order to be completely successful with hemostasis, we are going to discuss the fact that you require several blood factors as well as different types of ions and electrolytes like calcium, which was mentioned before, to make sure that all 3 steps are able to be performed at maximum capacity. Now, the 3 steps are going to be vascular spasm, platelet plug formation, and coagulation. And it will occur in sequential order, meaning that whenever there is damage to the blood vessel and blood loss is noticed, the first step will be vascular spasm, which will allow time for the platelet plug formation to occur. And at the end of the cascading reaction, you will then get to step 3, which will be the coagulation. So let's go ahead and take a look at the illustrations that are at the bottom of the PowerPoint so we can kind of see what these 3 steps entailed. And as you can see, our first picture is going to recognize, or illustrate, I should say, our vascular spasm step. So this is the first step involved in hemostasis, and really this step is mostly done by the blood vessels, not even the platelets. But what will happen is whenever there is damage done to the blood vessel and there is excessive blood flow that can be lost, we see that vascular spasm will entail that the blood vessel will do vasoconstriction. And vasoconstriction means that it will taper down the size of the lumen, making it harder for blood to flow out of the damaged area. Also, what we see happening, and you can see it in the illustration, is that the area of damage, you're going to have these little threads that start sticking out into the lumen. These are actually collagen fibers, and these are very important because what's going to end up happening is as the platelets are free floating, and you can see the platelets right here with the little purple dots, as they're free floating through the blood vessel, they're actually going to get stuck on these collagen fibers that are sticking out. And the longer the more platelets start sticking to these collagen fiber, the easier it is to transition from step 1 to step 2. Step 2 is when you have enough platelets in the area of injury that you can start forming a little plug. So you just have like this massive clump of platelets. And this is then called a platelet plug formation. Now, this is actually an example of a positive feedback system because it turns out anytime you have a few platelets that start clumping, or I should say plugging together, they will actually recruit over additional platelets to the site of injury. So they'll increase the stimuli so you can have a more heightened result. The more result you have, the more platelets, the more they increase the stimuli, just so you can have more and more platelets make their way over to the site of injury. Now, keep in mind that with the platelet plug, the platelets are just simply plugging or clumping together. Eventually, the plug will become so large that the platelets will actually pop open, and as they pop or lyse open, that will then allow for the third step to occur, which is coagulation. Now, coagulation will involve the release of fibrin, which is a sticky protein that's housed within the platelets, and that fibrin will then go ahead and form the actual blood clot. So on your illustration, you can see that in addition to the purple of the platelets, you now have a blue string that kind of wraps around everywhere. That is going to be the fibrin that is kind of holding the clot together. I have another illustration right here showing you the events of hemostasis. So you can see in your first step, you're going to have your vascular spasm. Notice how the little arrows are pointing inwards to indicate the fact that the smooth muscle layer of your blood vessel is doing vasoconstriction. And at the same time, even though it's not really pictured here, you have your collagen fibers that are sticking out, making it easier for your platelets to adhere to the site of injury. So as the platelets start to gather and attach to the collagen fiber, we see that the platelet plug starts to form, and they'll recruit over more and more platelets, releasing different chemicals to make a positive feedback system so that the plug will get larger and larger. And eventually we see that the platelets will go ahead and release their fibrin, which, as I mentioned to you before, is going to be a little sticky substance, and that will then allow for a full clot to form. And when that happens, you have reached your third step, which is coagulation. So keep in mind, you have to do this in sequence of steps. So the first step will be your vascular spasm, then your platelet plug formation, and last but not least, you'll have coagulation that will occur. Now, in order for this whole process to be successful, as I mentioned to you before, there will be different clotting factors and different electrolytes that will come and play a role in it. So what I want to do with you is I want to quickly discuss figure 17.14. This talks about all the different phases that are involved to actually get your plug or your coagulation to occur, or hemostasis to occur, from step 1 all the way to step 3. So I know the picture is a little bit small, so what I'm going to do is I'm going to subdivide it into our next slides. We're going to take a look at phase 1 first, and then we'll take a look at phase 2 and 3. And when you look at this illustration, what you want to notice is that you basically have a cascading pathway, meaning that each step activates more and more type of clotting factors or different receptors that will ultimately lead you to your end result, which of course is coagulation. So let's start with phase 1. It turns out that the actual process of hemostasis can be activated by what we call the intrinsic pathway or the extrinsic pathway. Now, the intrinsic pathway, intrinsic means internal, means that signals within the blood vessel itself will be sent off to go ahead and indicate the need for platelets. So on your PowerPoint, it says right here, it says the vessel endothelium will rupture, exposing underlying tissue. So those little collagen fibers that we've seen, that will be an intrinsic pathway activation because it occurs within the blood vessel that's injured itself. And when the collagen fibers become exposed, then we see that the platelets can cling to it and set off that positive feedback system that will recruit more and more cell fragments over to the site of injury. The opposite of the extrinsic pathway is going to be the extrinsic pathway, and this is going to indicate cells that are outside of the blood vessel that are experiencing trauma. So these could be, for instance, the muscle cells that are injured. They can be your skin cells that are injured, and they're going to go ahead and start setting off different chemical messengers, including things like tissue factors, which will go ahead and also recruit platelets over to the site of injury. Now, most of the time what we see happening is that the intrinsic pathway and the extrinsic pathway will work together and they'll be activated together. And as you could see at the bottom of the illustration, they're going to set off a series of clotting factors. Now, it's not important for you to memorize these different clotting factors, but what I do want you to know is regardless of which pathway is activated, you will always see the commonality in the fact that they will require calcium to be successful. So here's the calcium for the extrinsic pathway, here's the calcium for the intrinsic pathway, and regardless of which pathway is activated, they will always lead to the activation of factor 10. That's the part that I want you to memorize. And factor 10 is a very important clotting mechanism or clotting factor because it's going to cause the activation of, or I should say the conversion of prothrombin into thrombin. And I'm going to talk more about that in 1 second, but I just want to make sure that we understand what we should know about this particular illustration. So this is phase 1 of hemostasis. We want to make sure that we know the difference between intrinsic and extrinsic pathway. You do not have to memorize the different clotting factors, but please know that both pathways will involve the use of calcium, and both pathways will lead to the activation of factor 10. In fact, when we do a clinical application and we take a look at hemophilia, which is a blood clotting disease, it's a genetic disease, what we see happening is that these patients are missing one or several of the clotting factors that are required to be successful in either the intrinsic or extrinsic pathway. Now, the good news is that with medical advances, they have been able to synthesize a lot of these clotting factors. So there are lots of medications out there that can provide a substitute for the innate missing clotting factor. But either way, what we see happening is at the end of phase 1, factor 10 will interact with prothrombin, and prothrombin will then go ahead and cause the activation of thrombin. This will be very important in phase 2 of our blood clotting step. So let's go ahead and take a look at the next slide. So here we see that prothrombin will activate thrombin, and then thrombin will allow us to migrate over to phase 3, where you will have the activation, or the conversion, I should say, of fibrinogen into fibrin. And you've seen fibrin before. That's going to be the sticky solution that's going to allow for the coagulation to actually occur, because it's going to form this like mesh network between the platelets, forming your full clot. So you have your intrinsic and your extrinsic pathways. Both require calcium. Both will lead to factor 10. Factor 10 will allow prothrombin to allow the activation of thrombin, and thrombin will then allow the activation of fibrinogen into fibrin. And from fibrin on, you can see that the clot will form. Also, side note, look, it requires even more calcium at this step as well. Now that you have the clot that's fully formed and you're minimizing your blood loss, it turns out that we can't really let the clot stay there for too long, because at the end of the day, it's kind of like setting up a barrier inside of your blood vessel. So it's going to hinder blood flow. So we don't want the clot to be there any longer than it really needs to be. So now what we need to do is, once it's initially formed, we're all about stabilizing it, and then we're going to start removing it. And the removal process can even start like within 30 minutes of the clot forming, because it turns out that within the platelets, you have the proteins actin and myosin that will start contracting, and these will go ahead and not only assist with pulling the blood vessel edges together, making it easier for the blood vessel to heal up, but it will also start loosening up the platelets so that the clot starts slowly retracting, slowly starts to fall apart. We also see that as this is occurring, that there is a quite amount of liquid that is being exchanged between the platelets. And the liquid that we see is going to be called serum. Serum is very similar to plasma, but no longer contains clotting factors. And that's because these clotting proteins have been utilized. So as you're doing your homework or you're just kind of reading up on this, if you see the mention of plasma versus serum and you want to know what's the difference, serum basically means that there's no clotting proteins found anymore because hemostasis has occurred and your platelets have utilized it. The other thing that we want to do, obviously, is as the platelets are starting to retract and starting to fall apart, is we want to make sure that the actual blood vessel is starting up its healing process, as well as all the different endothelium cells, muscular cells, and connective tissue cells that are surrounding the injured area. And the platelets will actually also assist with that because they're able to secrete two very important growth factors. The first one is called the platelet-derived growth factor, and this one actually has an aim on smooth muscle cells and fibroblasts, and this will aim at the blood vessel wall to kind of start rebuilding itself and repairing its damaged area. At the same time, the platelets will also go ahead and secrete vascular endothelium growth factor, VEGF. VEGF is a very potent growth factor. It has many different effects. It can help with the endothelium cells that are surrounding the blood vessel to help multiply them and to restore them. We also see that it will play a role in the endothelium lining, so the internal lining of the blood vessel itself. But also what it can do, VEGF, is that it will stimulate new blood vessel growth. So if there is a site of injury where blood vessels have to kind of be regrown or restored, VEGF will be a very important growth factor in restoring that injured area. Now, let's go back to our clot. So how do we actually go about, what are the steps that are involved to actually pull the clot apart and get the platelets to be completely removed from the site of injury? Well, in order to do that, we're going to need to remove the fibrin, the sticky protein, right? So we're going to do fibrinolysis, which is the process of actually removing this mesh network. Usually this is towards the end part of the clot retraction step. For many injuries, this will be like a day or 2 days after the clot is kind of initially formed until it actually completely falls apart. And it will require a specific plasma protein called plasminogen. And plasminogen, which is generally just like trapped in the clot itself and released by the platelets, as plasminogen starts to be released, it's going to be converted into plasmin. And plasmin is almost like a pair of sharp scissors. It's able to cut to the fibrin and start pulling them apart. And as it does so, it's assisted by things like tissue plasminogen activator, factor 12, thrombin will actually play a role in this as well, and it will just allow for the plasmin to just cut to the fibrin as quickly as possible, thereby releasing the clot and completely dissolving it. There are also different ways that we can limit normal clot growth. So for instance, if you are not injured, we don't want an unnecessary clot to form. Also, if you are injured, we want to limit the clot size to the site of injury. We don't want it to become abnormally large because at the end of the day, obviously that will hinder your blood flow in that particular area. So there are many different ways that we can limit clot growth or regulate normal clot growth or prevent abnormal clot growth. One of them is that with blood flowing at its normal speed, usually you have a swift removal and dilution of the different clotting factors that are involved in the cascading reaction of the intrinsic and the extrinsic pathway. We also see that the activated clotting factor, once they have performed their role, they will be inhibited, meaning that they can't activate or recruit over any more platelets. We also see that there's a limited amount of thrombin that will be restricted to the clot by the fibrin threads. So this will obviously prevent the clot from getting larger, because remember, the thrombin is the protein that you need to go ahead and convert your fibrin into its final form. Towards the bottom of the slide, we also see a mention of antithrombin. That is another protein that is floating around that will actually inactivate any unbound thrombin that might escape away from the site of injury. Heparin. Heparin is a very potent anticoagulant. Heparin comes courtesy of our basophil cells. Now, the name should look familiar because the basophil cell is one of your granulocytes. It's a leukocyte. We talked about the basophils as functioning in producing massive amounts of histamine, but it can also produce heparin, which is an anticoagulant. And very similar to its histamine production, the mast cells can also produce heparin. So that's another way that mast cells and basophils have some similarities in their function. And heparin will basically inhibit thrombin by enhancing the effects of the antithrombin mentioned above. Another way that we can prevent an undesirable clot, and this is one that I've already mentioned, is by preventing platelet adhesion. So we don't want the platelets to clot or plug together if the blood vessel is fully healthy and there's no injury. And the easiest way to do that is to take a look at the actual anatomy of the blood vessels. And what we see is that usually it has a very smooth lining, and part of that is done through the secretion of prostacyclin, which gives almost like a little slippery feel to the lumen of the blood vessel. So if there's no injury and there's no collagen fiber sticking out, there will be no need for the platelets to kind of clump together. Nitric oxide also plays a role in producing some of these antithrombotic substances. Alrighty, so now that we have become, I'm going to call us experts on erythrocytes, leukocytes, and platelets, let's go ahead and take a look at our last topic for chapter 17, which is going to be all about blood transfusions. And blood transfusions are very important to discuss because we know that blood plays a very essential role in our hemostatic ability. So if there's any type of clinical application that will cause your blood level to be severely reduced, we need to have an alternative to kind of substitute that loss quickly, and the blood transfusion is an excellent way. So just to give you an idea, if you lose about 15 to 30% of your blood, it will cause pallor, which basically means lightening of the skin. You'll become very pale, and weakness, severe weakness, because there's not enough oxygen carrying capacity, and also you will become immunocompromised, right? If you lose more than 30%, you have an extreme high chance of going into fatal shock. And this is due to the fact of the extreme amount of pressure that will be placed on the heart, and the reduced blood flow will actually make it harder for the heart to go ahead and pump blood. You'll have a severe reduction of venous return, meaning the blood is not returning to the heart, so it can't equally distribute it throughout the body, which can be a very stressful situation. And this, of course, goes hand in hand with the fact that you are also not getting enough oxygen, and you're definitely not getting enough protection from your white blood cells. Now, can we just go ahead and give blood just from one person to the next? Unfortunately, it turns out no, because in humans, we have different blood typing mechanism, and this is determined from a genetic standpoint. So that means that your father and your mother's contribution in their egg and their sperm will determine your genetic blood type, and we're going to talk about it in a little bit. But basically what ends up happening is that if you're doing a blood transfusion, meaning that you're donating blood or you're receiving blood, it can be done many different ways. A lot of times we can do what we call a whole blood transfusion. We can do a packed red blood cell transfusion. We can also do a plasma antibody transfusion. It really depends on exactly what we're looking for. Probably the most common use for blood transfusion is when we want to look and we want to replace our red blood cells. In that case, what you would do is you would do a packed red blood cell transfusion. And in a packed red blood cell transfusion, what they do is they take the donated blood and they basically separate the plasma and the white blood cells, so the liquid aspect of the blood and your white blood cells that might be floating around. They are separated, and the red blood cells are kind of clumped together, and that is then the donation that is then received by the patient. And this is all about restoring your erythrocyte levels and, of course, thereby restoring your oxygen carrying capacity. There are also what we call whole blood transfusions. Whole blood transfusions means that the patient will receive all the plasma as well as all the formed elements. If you've ever donated blood, usually what you do is you donate a whole blood transfusion. So you'll sit there for about 30 to 45 minutes. They'll take blood from you, and then on a laboratory setting, they'll go ahead and they'll be able to separate them into a packed red blood cell donation. And also what they'll do is the plasma is often very important, because in the plasma you can have particular antibodies floating around that might be essential. So especially right now in the situation that we're in with COVID, one thing that the CDC is actively recruiting are patients that were diagnosed with COVID and successfully got over the disease. Well, their plasma is filled with antibodies that are very specific to the COVID virus. So they are looking for people to go and donate their plasma so that we can take those antibodies and we can donate them to patients who are not doing so well and have very severe symptoms of the COVID. And those antibodies can provide a boost to their immune system, because once again, they are specific for the COVID virus that is destroying the body and causing the severe symptoms to occur. Now, how exactly do we determine who you can donate blood to? As I said to you before, it's determined from a genetic standpoint, and it's all about taking a look at different receptors or antigens or agglutinogens that you find on the surface of your red blood cells. There are many different ways that you can blood type. There are a boatload of different receptors. Different countries will use different processes, but by far the most popular one is to take a look at the receptors that we call ABO and the RH. So these are two different sets of receptors. And for those of us who know our blood type, we know that when you report your blood type, you'll report a letter and then you'll say either positive or negative. So you'll say, for instance, I'm A positive, I'm B negative, I'm AB positive. Well, the ABO will determine what letter, and then the RH group, that will determine if you're positive or negative. So let's go ahead and take a look at, there's a little chart that I want to show you, and we'll talk about exactly which antigens will go with what blood type. All right, so this is table 17.4, and it's a very informative table. So let's start all the way on the left-hand side, and we're going to work our way through it. So first off are our actual blood groups. So these are your phenotypes. This is what determines, this is what you tell people that your blood type is, right? So you tell them, hey, I'm blood type AB, I'm blood type B, I'm blood type A, or I'm blood type O. So those are your four options for what your phenotypical blood group is. Now, what exactly is going to determine which category you fall into? Well, that will be determined about the red blood cell antigens. Antigens are little receptors, more specifically agglutinogens. And the agglutinogens are the same thing as the antigens, are the same thing as the receptors. They are found on the surface of your red blood cell. And it turns out that we have three options. You can have an antigen that's coded for A, you can have an antigen that's coded for B, and then you can have an antigen that's coded for O. Now, the O antigen is called the naked antigen because even though the antigen or the receptor is there, your immune system can't detect it. So oftentimes you'll hear about the naked antigen or a naked red blood cell, and that's because it has the O receptors. Now, for those of us who remember our genetics, we know that there's often a dominant versus a recessive, and it turns out that with blood typing, both A and B are dominant, so they have codominancy. Now, O is going to be your recessive genotype. What does that mean? Well, as humans, we inherit two genotypes, one from mom and one from dad. And what we see happening is, as long as you have at least one A, you are definitely going to be type A blood. If you get at least one B, you're going to be type B. Now, what if you get an A and a B? Well, both of those will be expressed. So then you'll be blood group AB. In order for you to be type O, you need to actually receive both O's from both parents. Okay? So for instance, you can see it right over here. For your AB antigens, if your patient is AB, that automatically means that one parent gave them an A, the other one gave them a B. If your patient is type B, that means that they have at least one B antigen. The other parent could have given them a second B, so they could have been homozygous, meaning both parents gave them the same one, or they could have received one B and one O. Because the O is recessive, we ignore it, and B is the one that's then expressed. Same thing goes for people with blood type A. They have at least one A antigen from one parent, and the other parent could have given them another A, or that A could have been followed up by an O. And once again, because the O is recessive, it's ignored. If you are type O, notice how it says you have no antigens, but in reality, you basically have two antigens, both labeled for O, but they're both being ignored by the immune system. So it basically has a naked red blood cell that it's observing because it can't recognize the O receptors. Now, why is all this important? Well, it turns out that as soon as your antigens are being expressed, you start producing antibodies against the unknown. Now, these antibodies will be found in the plasma. So right over here, the plasmas will have antibodies, and the antibodies are also called agglutinins. If you ever get confused between agglutinogens and agglutinins, keep in mind that agglutinogens end with a G-E-N, which is the same thing as an antigen. Okay, so agglutinogens are antigens, which are your receptors. They're the ones that determine your blood type, and agglutinins are antibodies, and the antibodies you will develop against the unknown. So what your body is not familiar with. So remember, we're talking about blood typing in this case, which means that our antibodies that are floating around are going to be specific for A or B. Now, why are they not going to be specific for O? Because remember, your immune system doesn't recognize or can't see the O, and because it can't see it, because it's a naked receptor, you can't produce an antibody against it. All right? So let's take a look at this column. Actually, I'm going to start over here by B. If you are blood type B, that means that your body knows all about the little B receptors, right? You see them right here on our red blood cell. So what we see happening is that your immune system will produce antibodies against A because it doesn't know the A receptor. If you're blood type A, your body knows all about A. You can see it right here on the red blood cell. So in the plasma, you'll have antibodies against B. So see how you're producing antibodies against the unknown receptor. Now, what happens if you're AB? If you have both of the receptors? Well, in that case, there's no unfamiliar version, right? Because we're ignoring type O. So you actually have no antibodies that are floating around because your cells, your red blood cells, are familiar with both A as well as with the B receptor. Now, let's go all the way down and let's take a look at patients that are type O. What happens over there? Well, in this case, our little naked red blood cell has no idea what A or B looks like, right? Because it's O, it has two double O's. So that means that in the plasma, we'll have antibodies floating around against both A and B. Now, what does this all have to do with a blood transfusion? Well, when you're doing a blood transfusion, you're introducing red blood cells into the patient's system. We want to make sure that the patient doesn't have antibodies in their plasma that will be able to recognize foreign antigens and thereby cause agglutination or clumping to occur. So for instance, if you're looking at your patient and they have blood type B, if you go ahead and give them blood type A as a transfusion, the minute the blood type A enters their bloodstream, the antibodies that are naturally found in their plasma against anti-A will recognize the foreign A antigens from the transfused blood, and it will cause coagulation, clumping of the red blood cells. That was very dangerous because it can clog up smaller capillaries and blood vessels, and it can actually be detrimental to the patient's life. So we don't want the blood flow to be interrupted at all. We want to make sure that we have a proper blood procedure when it comes to blood transfusion. So always keep in mind which antibodies are present. And what we see happening is that if we migrate over to this column right here, we can see that when it comes to blood transfusion, you can always receive the blood type that you are. So if you're AB, you can receive AB. If you're B, you could receive B. A can get A, and O can get O. But there are also some other options because that's what your body is familiar with, right? The blood type that you have, you can receive that blood. But it also turns out that you can always receive O. And why is that? Well, because O is the naked red blood cell. The immune system doesn't recognize it. So I can take O blood and put it in anybody's bloodstream because those receptors will not alert the immune system. And that is why O, excuse me, is called the universal donor. It can go ahead and give blood to everybody. The universal recipient, the one that can receive blood from anybody, all blood types, is going to be AB, because AB can obviously receive its own blood type, AB. It can receive O, but it can also receive A by itself, and it can receive B by itself. And this is all assisted by the fact that they have both of the antigens on the red blood cells, but also by the fact that they have absolutely no antibodies that can cause a reaction within the bloodstream. Now, let's go all the way down and let's talk about O. We know it's the universal donor because it's the naked red blood cell. But what happens if you're type O and you need blood yourself? Well, it turns out that because floating in your plasma, you have antibodies against A and B, your only option is to receive blood type O. So O is the universal donor. It can give it to everybody, but unfortunately, when it's time for it to receive a blood transfusion, O can only receive O. All right, now what about RH? Because remember I said to you, if you know your blood type, you know your letter, and then you either have a positive or a negative. Well, the positive and the negative is the RH blood type. And the way it's going to work is that we're going to look at a different set of receptors or agglutinogens on our red blood cells. These are called the RH factors. And the one we're really interested in is the D antigen. They're called RH because they were discovered in the rhesus monkey. And what we see happening is as long as you inherit at least one D antigen, you are positive. So that means that if you have positive in your blood type, you can be what we call positive negative, meaning one parent gave you the receptor and the other didn't. Negative means you didn't get it. Or you could be positive positive. Both parents gave you the D antigen. My apologies. If you are negative, that means you're negative negative. Neither parents gave you that particular receptor. Now, something that's really interesting about the RH blood group is unlike your ABO blood group, you actually will not produce antibodies against it unless you are exposed to RH. What does that mean? Well, if you're RH positive, you really don't care if you're receiving RH positive or RH negative blood because you're positive, so you know what the receptor looks like. So you don't care if the blood you receive has the receptor, is positive, or it doesn't have the receptor, it's negative. However, if you are RH negative, you have no idea what the D antigen looks like. So what we see happening is that you will start producing antibodies against RH only when you're exposed to it. So it doesn't spontaneously form like how the ABO blood type we were talking about, how you get your anti-A and your anti-B automatically. Well, usually when you're about 10 months old, you start producing them. But that's a spontaneous formation of those antibodies. The Rh group, if you're Rh negative, you will only produce antibodies against Rh once you become exposed to it. So that would mean, for instance, if you have blood type negative, if they mess up and they give you positive, that exposure of positive will allow antibodies to form. It also means that the first time you're exposed to it, your body will recognize the Rh as being foreign, but it won't be able to do anything with it because it doesn't have the antibodies that are required to fight off this quote-unquote foreign antigen. So what I mean is that, for instance, and I should be a little bit more specific, let's say you have B negative blood, and you go into the hospital and they give you B positive for a blood transfusion. If this is the first time that you're exposed to the positive, there's nothing to worry about because you don't have the antibodies to fight off the foreign entity. If you go in a second time into the hospital and they expose you once again to B positive blood, what happens now is that your body's had time to make these anti-Rh antibodies. So when your negative blood comes into contact with the positive blood for the second time, you're going to get agglutination or clumping, very similar to if they had given you A blood or AB blood. So the blood cells will be able to recognize the foreign antigen, and because they've had time to produce the antibody, you will get a reaction because of the mismatch. There's also this scenario called hemolytic disease of the newborn. And hemolytic disease of the newborn is when the mom is Rh negative and she carries a fetus that's Rh positive. And this can happen because, remember, in order for you to be positive, you just need to receive one receptor. So dad can donate the positive and mom gives the negative, but the baby will then be phenotypically positive. Let's go ahead and switch over to the next slide, and let's talk a little bit more about the hemolytic disease of the newborn. So here's a little illustration that I took from a McGraw-Hill book, and what we see happening is we have mom, and she's going to go ahead and go through 2 pregnancies. Now, as you can see, she's Rh negative, and the baby that she's carrying is going to be Rh positive. Now, during the first pregnancy, this is important to note, the first pregnancy, her immune system is going to recognize this foreign antigen. But because it doesn't naturally produce these antibodies, you know what, I'm sorry, I was incorrect, my apologies. I said during her pregnancies, and that's incorrect. The baby's blood is shielded from mom's blood during pregnancy. However, during childbirth, whether it's vaginal or through a C-section, the blood will start to mix. And as the blood starts to mix, the mom's body becomes exposed to the Rh receptor. There's nothing that's going to occur at that point because, remember, you're not born with antibodies against Rh. So assuming that mom has never been exposed to the Rh receptor before, the baby will be perfectly fine. And what we see happening is that there's absolutely no complications with the first pregnancy. Now, what we do see is that because there was exposure of the foreign Rh receptor to the mom's body, we see that in between the pregnancies, the antibodies start to form. Now, that means that during the second pregnancy and any other pregnancy that follows afterwards, if mom carries an Rh positive baby again, the antibodies will be able to recognize the foreign antigen because, remember, mom is Rh negative and her body does not know what Rh positive looks like, so it identifies it as a foreign antigen. And during the second pregnancy and any pregnancy afterwards, those antibodies are able to cross through the placenta and they will cause agglutination of the fetal red blood cell. And they call it hemolytic disease of the newborn because it will cause the red blood cells of the babies to start lysing, popping open. And this can be actually very detrimental to the child. So it's very important to know your blood type during your pregnancy because it's actually something that's easy to treat. They have a shot called a RhoGAM shot that actually shields the baby's antigen from the mom's immune system, and that shot is usually given around the 3rd trimester and right before birth. Now keep in mind that the hemolytic disease of the newborn is only applicable if mom is Rh negative. If mom is Rh positive, she knows what the receptor looks like. So she doesn't care if her baby is Rh positive, the same as what she is, or Rh negative, because negative means the receptor is not there, so there's nothing for the immune system to actually interact with. Now, going back to blood transfusions, that means that if you are A positive, you can go ahead and receive blood from A and O, and that A and that O can either be positive or negative. If you are A negative, you can really only receive A negative blood and O negative blood. If you're exposed to A positive blood, then remember the first time you're okay because you don't have the natural antibodies, but anytime after that you can get agglutination because of the mismatch of the Rh receptor. What if you're B positive? What blood can you get? Hopefully everybody said B positive, B negative, O positive, and O negative. All right, how about if you're B negative? Then you're limited to B negative and O negative. How about AB positive? Remember, ABs are universal donor when it comes to the letters, and it turns out that if you're AB positive, you can get all the letters A, B, O, and you don't care if the letters are positive or negative. However, if you're AB negative, you can also get all the letters, but all the letters would have to be negative. You got it. So the true universal recipient is actually AB positive, because it can receive all the letters and it doesn't matter if it's positive or negative. And then our last one is type O. If you're O positive, you can receive blood from O positive and O negative. And if you're O negative, you can receive blood from O negative. Now, I had mentioned to you before that O is the universal donor, meaning that we can give it to all the letters A, B, A, B. If you now factor in what you know about the RH, what would be the true universal blood donor, meaning that we can just blindly take this blood group and we don't even have to check the patient's blood type. We can just give it to them knowing that there would be no immune reaction at all. And I'm hoping that we said that the true universal donor is O negative, because O negative means that it doesn't have receptors for the letters and it doesn't have receptors for the RH. So it really is a truly naked red blood cell that the immune system of the recipient cannot recognize, thereby not build up a response against it. All right. Our last slide of this particular section takes a look at a test that oftentimes we'll do in lab, and that is if you have a patient who comes in and you want to test their blood type, the easiest thing to do is to induce agglutination or clumping by making a perfect match between their antigen and the antibody. Now remember, normally your blood is nice and fluid, and that's because the antigens or your agglutinogens are mismatched when it comes to your antibody, so they don't react. So if you're blood type A, you have antibodies against B. If you're B, you have antibodies against A. If you're O, you have antibodies against both A and B. And if you're AB, you're very social, so you don't need any antibodies. So what we see happening here is that if a patient comes in and they happen to be type AB, in a laboratory setting, we'll be able to recognize their agglutinogens for A and B, because we are going to dump antibody A on top of them and antibody B on top of it. And these antibodies are then able to interact with the agglutinogens, causing agglutination, which is the clumping that you see happening here in the plate itself. What about if your patient is type A? Well, if you're type A, you have agglutinogens for A, so that means that if I dump anti-A or A antibody on top of it, I'm going to make a perfect match and I'm going to get my agglutination. If I put antibody B on top of it, then that's what it looks like normally in your blood vessels. It's a mismatch, which means that the blood stays nice and fluid and there's no reaction. If you're blood type B, then when antibody A is dumped on it, you have your mismatch. So that's what it looks like in your blood vessels, no reaction. And if I expose it to antibody B, then you have a perfect match between the agglutinin and the agglutinogen, so you'll get your clumping, you'll get your agglutination. And last but not least, if you're blood type O, because you have no agglutinogens or the agglutinogens are naked, we see that there's nothing for the antibody to react with. So you can see that both antibody A and B will allow the blood to stay nice and fluid. And this really demonstrates why O is the universal donor, because we can give it to anybody and there's nothing for the agglutinins or antibodies to interact with. So therefore making it a very easy choice when it comes to blood transfusion. All right, everybody, that is it for our chapter 17. With the ending of chapter 17, that means that it's almost time for us to take exam number 1. So please make sure that you go through your notes. Make sure that you reach out to me if you have any questions, comments, and concerns. And also keep in mind that every exam has a homework that goes along with it. So definitely keep an eye on your due dates, which are listed in the syllabus and the class schedule on Canvas, and make sure that you get your homework done through mastering by its due date. All right, so we are going to go ahead, and our next challenge will be to, or I should say our next objective will be to take our exam number 1, and after that we'll come back to our lectures and we'll take a look at chapter 18, which will continue to focus on the cardiovascular system, but now we're going to shift our focus from blood over to the heart. So it will be another interesting chapter to talk to you about. All right, bye for now.